Gonorrhea, causative organism, diplococci, gram-negative, kidney-shaped, non-motile, non-spore-forming, mode of transmission, sexual contact, and asexual transmission. Asexual transmission, contaminated towels, instruments, contaminated hands. Sexual contact, heterosexuals, urethra in males, urethra and cervix in females. Homosexuals, urethra in active homo, rectum in passive homo. Orogenital sex, urethra and pharynx. Clinical picture: genital affection in males, genital affection in females, extragenital gonorrhea, gonorrhea in children, and metastatic gonorrhea. Primary site in males: anterior urethra, penile urethra, extension to posterior urethra, pelvic urethra is considered as a complication. For females, urethra and cervix. Symptoms: for males, gonococcal anterior urethritis presenting with urethral discharge, profuse, purulent, greenish yellow, urethral discomfort, dysuria, frequency of micturition, hematuria, urgency, constitutional symptoms, hyperemia and edema of urethral orifice if infection extends to posterior urethra. 50% of cases are asymptomatic in females. Others may have mild soreness of the vulva, mild dysuria and frequency, scanty mucopurulent discharge, low back pain or lower abdominal pain. Complications in males: complications of anterior urethritis, Tysonitis, litoritis, paraurethral infection, periurethral abscess, coperitis. While in females we have cystitis, skinitis, Bartholinitis, which may proceed to abscess or cyst formation, salpingitis, oophoritis, tube ovarian abscess, pelvic peritonitis, pelvic inflammatory disease, FIDS, Hugh-Curtis syndrome, which is perihepatitis, inflammation of liver capsule, may follow gonococcal or chlamydial pelvic inflammatory disease because the organism spread along lymphatics or along peritoneum. While in males, complications of posterior urethritis, acute prostatitis and prostatic abscess, seminal vasculitis, epididymitis, obstructive infertility followed by lateral cases, cystitis. And don't forget that balanophthitis, inflammation of glans, penis, and prepuce in uncircumscribed patients with urethral stricture, coperitis, periurethral abscess, paraurethral gland infection, litoritis, and Tysonitis are complications of anterior urethritis. Extragenital gonorrhea, proctitis, pharyngitis, conjunctivitis, disseminated gonococcal infection, rare complication of neglected gonorrhea, occurring mainly in women and manifested clinically by dermatitis, arthritis, endometritis, meningitis, hepatitis. Diagnosis of gonorrhea: gram-stained smear, culture modified Thayer-Martin medium, colonies confirmatory test, gonozyme test, direct immunofluorescence, serological, and 2-glass urine test. Gram-stained smear: gram-negative diplococci intra and extracellular with polymorph nuclear cells. Simple test, useful only in acute gonorrhea in males. False negative results are common in females and in chronic gonorrhea in males. Culture indications: culture essential for definite diagnosis, especially in gonorrhea in females, chronic gonorrhea in males, extragenital and metastatic gonorrhea. Medico-legal proof. Colonies confirmatory test, gram-stained smear examination for colonies. Oxidase test, oxidase reagents turn gonococcal colonies black. Sugar fermentation test, gonococcus ferments glucose only. Gonozyme test, enzyme immunoassay test designed for detection of gonococcal antigen. Direct immunofluorescence test, most specific, most sensitive. Serological tests, complement fixation test, 2-glass urine test to differentiate anterior from posterior urethritis. The patient is asked to void the first few drops in a flask and the remainder of urine in another one. In anterior urethritis, the first glass contains more pus cells than the second, while in case of posterior urethritis, 2 glasses are almost indifferent. First line therapy for uncomplicated gonorrhea: single dose of procaine penicillin, 4.8 million units intramuscular, is given with 1 gram probenicide orally to delay renal excretion of penicillin. Patients refusing injection can be given ampicillin single dose orally with oral probenicide, or amoxicillin single dose orally with probenicide. Patients sensitive to penicillin can be treated with erythromycin, azithromycin, tetracycline, doxycycline. Erythromycin and tetracycline 500 mg per 6 hours for 5 days. Azithromycin 1 gram single oral dose. Doxycycline 200 mg single oral dose. Patients not responding to penicillin and may have penicillinase producing gonococci can be treated with kanamycin 2 gram intramuscular, spectinomycin 2 gram intramuscular, cefotriaxone 250 mg intramuscular, quinolone single dose of ciprofloxacin, norfloxacin, or oflofloxacin. Disseminated and complicated gonococcal infection, hospitalization and treatment for 1 to 2 weeks with higher dose of the previously mentioned drugs. Non-gonococcal urethritis, chlamydia trachomatis, mycoplasma, ureaplasma, urealyticum, mycoplasma hominis, trichomonas vaginalis and intrameatal lesions, herpes progenitalis, chancre, lymphogranuloma venereum, condyloma acuminata, others, uropathogens, stone urethra, oxaluria, and we have comparison between gonorrhea and non-gonorrheal urethritis prevalence. Previously more common STDs, while the non-gonococcal urethritis now are more common than gonorrheal urethritis. It contributes to 15 to 20% of the patients attending at STDs clinics. Causative agent in gonorrhea, Neisseria gonorrhea, while in non-gonorrheal urethritis we have chlamydia trachomatis, D, E, F, G, H, I, J, K, mycoplasma, mycoplasma hominis, ureaplasma urealyticum, trichomonas vaginalis, intrameatal lesions, chancre, condyloma acuminata, lymphogranuloma venereum, herpes progenitalis, others, uropathogens, stone urethra, oxaluria. Incubation period for gonorrhea 2 to 5 days, while in non-gonorrheal 1 to 5 weeks. Symptoms in gonorrhea: profuse purulent greenish yellow discharge with dysuria, while with hyperemic urethral orifice, while in non-gonorrheal scanty mucoid urethral discharge, urethral discomfort, frequently asymptomatic, with scanty mucoid urethral discharge on urethral milking. Local complications of gonorrhea is less than the non-gonorrheal because patients seek treatment early, but in neglected cases they are severe, while in non-gonococcal complications are more common, as mild symptoms usually lead to neglect or delay of treatment. Systemic complications, perihepatitis in gonorrheal, and in non-gonorrheal we have Reiter's syndrome, triad of urethritis, conjunctivitis, arthritis with perihepatitis. Gram-stained smear, gram-negative diplococci in gonorrheal, while it's negative in non-gonorrheal. Culture, modified thyroid Martin medium, treatment penicillin, cephalosporins, quinolones, while in non-gonorrheal tissue culture for chlamydia, gene detection by PCR, with treatment by tetracycline, macrolides, and quinolones. Other locally presenting STDs, condyloma acuminata or venereal warts by human papillomavirus, condyloma acuminata, warty outgrowths which have the following characters: multiple, cauliflower-like, usually for penile or external valvular lesions, flat on mucous membrane of cervix, dry, non-oozing, skin-colored or hyperpigmented, variable in size from pinhead size to large tumor, Buschke-Levenstein tumor. Then sites in males: penile shaft, pubic area, glans penis, intrameatal, perianal groin. In females: cervix, vagina, vulva, pubic area, perianal. Aggravating factors: immune suppression causing marked increase in size and number of the lesions, as pregnancy, diabetes, AIDS, immunosuppressive drugs. Complications: cancer cervix, laryngeal papillomatosis. Infants may acquire the virus from maternal passage during labor and develop papilloma in the larynx. Differential diagnosis: condyloma lata. We're going to compare between condyloma acuminata and condyloma lata. Etiology: human papillomavirus, condyloma lata, treponema pallidum. Sites: condyloma acuminata, any part in the genital tract, may be intrameatal, while condyloma lata, sites of friction, mainly perianal. Condyloma acuminata, infective, cauliflower surface, skin colored or hyperpigmented, moist and oozing, pedunculated, treated by local podophyllin, while condyloma lata, highly infective, flat-topped surface, grayish-white surface, dry, sessile, treated by penicillin injection. Cytology, characteristic coilocytes, biopsy. Treatment: repeated careful painting of the lesions with 25% polyethylene resin in alcohol or in liquid paraffin. This is contraindicated in pregnancy. Now I'm talking about condyloma acuminata, don't forget. Other chemical cauterizing agents: trichloroacetic acid, electrocautery, surgical remover, less preferred, intralesional systemic alpha interferon. Molluscum contagiosum, caused by pox virus, treated by phenol cauterization and curettage. Clinical presentation: viral disease seen in the hands, face, trunk of children, being transmitted by direct contact in adults, multiple pearly white papules with characteristic central amplification, developed on the external genital skin, pubic region, being transmitted sexually. Then we have systemic presenting STDs. Acquired immune deficiency syndrome, AIDS. Etiology: causes of organism: AIDS is caused by HIV, which belongs to the retroviruses, characterized by presence of reverse transcriptase enzyme converting RNA into DNA. We have two types, 1 and 2. 1, most AIDS in Western countries. 2, most AIDS in West Africa. Modes of transmission: sexual transmission, donation procedures, transplacental sexual transmission, whether homo or heterosexual, and donation procedures: blood transfusion, organ transplantation, contaminated needles and syringe. Then we have contaminated razors. Transplacental, from infected mother to her child. Unproven modes of transmission include mosquito bites, non-sexual contact, cough, sneeze, food. Risk groups: homosexuals, female partners of homosexual, bisexual men, prostitutes, promiscuous individuals, intravenous drug abusers, patients needing repeated blood transfusion, organ transplant patient, occupational. Pathogenesis: lymphocytes are the main cells of the immune system. There are two main types, B and T. The T helper and suppressor. The virus selectively attacks CD4 receptors on the T helper lymphocytes, leading to their destruction and immune deficiency. The immunological defect makes the patient susceptible for certain types of protozoal, viral, fungal, bacterial, parasitic infections, opportunistic infections. Clinical presentation: following incubation period of variable duration, the disease passes through those stages: acute retroviral stage, asymptomatic stage, persistent generalized lymphadenopathy, AIDS-related complex, and full-blown AIDS. Acute retroviral stage: in 10% of infected persons, glandular fever-like symptoms occur concomitant with seroconversion. Asymptomatic stage: the patient is clinically free but serologically positive and infectious. Persistent generalized lymphadenopathy: all lymph nodes, especially the cervical and axillary groups, show mobile non-tender enlargement. AIDS-related complex: full-blown AIDS, characterized by opportunistic infections and Kaposi sarcoma and other malignant disorders. Wide range of clinical conditions hardly makes the diagnosis direct or classic. Classical case definition: at least 2 major criteria and at least 2 minor criteria in absence of known cause of immune suppression. Major criteria are fever for more than 1 month, diarrhea for more than 1 month, weight loss more than 10%. Minor criteria are oropharyngeal candidiasis, generalized lymphadenopathy, chronic disseminated herpes simplex, recurrent herpes zoster, generalized pruritic dermatitis, cough for more than 1 month. Either Kaposi sarcoma or cryptococcal meningitis is sufficient by itself to diagnose AIDS. Neurological manifestations: HIV, encephalopathy and myelopathy, encephalitis, meningitis, retinitis, space-occupying lesions, tumors, opportunistic infections. Respiratory manifestations: TB, pneumocystitis, cardiac pneumonia, pulmonary Kaposi sarcoma. GIT manifestations: malignancy, Kaposi sarcoma, opportunistic infections, monorial infections, straguloids, stercoralis infestation. Hematological manifestations: lymphoma, cerebral lymphoma, B-cell or Burkitt's lymphoma. Dermatological manifestations: seborrheic dermatitis-like lesions, which is the most common. Viral diseases: oral hairy leukoplakia, chronic ulceration, especially perianal, multi-dermatomal bullous and ulcerative lesions, genital and common warts. Molluscum contagiosum: bacterial diseases, folliculitis, syphilis, monilial oral thrush, angular stomatitis, Kaposi sarcoma, violations of use and plaques commonly affecting lower limbs and oral mucosa, basal cell carcinoma, squamous cell carcinoma, and melanoma. Lab diagnosis: detection of HIV antibodies are detectable 4 to 8 weeks after exposure to the virus. Screening test: ELISA, confirmatory test, Western blot test. Detection of HIV, HIV culture, HIV antigen test, mainly used for detection of HIV core antigen P24, limited application. Treatment: prophylaxis, general measures, treatment of infections, and anti-HIV drugs. Prophylaxis: sex education about AIDS and its modes of transmission, screening of blood donors, strict measures against drug addiction, lab precautions in handling specimens of AIDS patients, general community measures against illegal sexual practices. Surgery candidates should have preoperative screening for AIDS, general measures, hospitalization and isolation, treatment of infections, TB, anti-tuberculosis medications, herpes simplex, acyclovir, condyloma acuminata, interferon, moniliar nystatin, and pneumocystitis cardiae, pneumonia, pentamidine, trimethoprim. Anti-HIV drugs: nucleoside reverse transcriptase inhibitors, RTIs, and non-RTIs. RTIs, they inhibit virus replication through inhibiting reverse transcriptase enzyme, zidovudine. Non-nucleoside reverse transcriptase inhibitors, non-RTIs, nevirapine, and protease inhibitors, squinavir, prevent cleavage of viral protein precursors. And now we are gonna discuss andrological emergencies. Acute scrotum. Acute scrotum presents as testicular pain or swelling, which should be considered as testicular torsion till proved otherwise. Testicular torsion represents surgical emergency because the likelihood of testicular salvage diminishes the duration of torsion. Age of patient is important. Testicular torsion is the most common in neonates and post-pubertal boys. Although it can occur in males at any age, the onset and duration of pain must be carefully determined. The testicular torsion is usually begins abruptly. The pain is severe. The patient appears uncomfortable. Moderate pain developing gradually over few days is more suggestive of epididymitis or appendiceal torsion. Diagnosis of selected conditions responsible for acute scrotum. The condition: testicular torsion, acute onset, early puberty, diffuse tenderness, negative urine analysis, negative cremasteric reflex, treated surgically. Appendiceal torsion, subacute onset, prepubertal age, localized tenderness to the upper pole, negative urine analysis, positive cremasteric reflex, bed rest and scrotal elevation as treatment. Epididymitis, insidious onset, adolescence, epididymal tenderness, positive or negative urine analysis, cremasteric reflex is positive, treated by antibiotics. Torsion testis and epididymoorchitis. Torsion testis occurs in neonatal or prepubertal with sudden move, normal temperature. Scrotal elevation causes severe pain. Scrotal duplex is avascular. This is the most important. Surgical exploration. We have the torsion of the affected testis and fixation of both. While in epididymoorchitis, it occurs at any age. History of UTI. Temperature is elevated. The pain or no pain. Scrotal duplex is hypervascular. And surgical exploration, we have nothing. It's closed. History of trauma doesn't exclude diagnosis of testicular torsion. Scrotal trauma incurred during sports activities or rough play. Physical examination can assess the severity of pain by observing the patient before beginning of physical examination. Diagnostic studies: urine analysis should be performed to rule out urinary tract infection in any patient with acute scrotum. Urgent scrotal duplex is required to detect testicular avascularity. So a trial of the torsion guided by duplex may be done. Spermatic cord torsion. The Bell-Clapper deformity is one underlying cause of testicular torsion in older children. In this deformity, the testicle lacks normal attachment to the tunica vaginalis and therefore hangs freely. As a result, the spermatic cord can twist. Torsion of testicular appendages. The appendix testis Mullerian duct remnant located at the superior pole of the testicle is the most common appendage to undergo torsion. The epididymal appendix, located on the head of the epididymis, is a Wolffian duct remnant and may also become twisted. Epididymitis or orchitis in adolescents, young adults, often related to sexual activity, doesn't present with UTI. Scrotal trauma, severe testicular injury, which is uncommon and usually results from direct blow to the scrotum or straddle injury. Damage occurs when the testis is forcefully compressed against pubic bone. Penile fracture, traumatic rupture of the corpus cavernosum. Traumatic rupture of the penis is relatively uncommon and is considered andrological emergency. Sudden blunt trauma or abrupt lateral bending of the penis in an erect state can break that markedly thin and stiff tunica albuginea, resulting in fractured penis. One or both corpora may be involved, and concomitant injury to the penile urethra may occur. Urethral trauma is more common when both corpora cavernosa are injured. Penile rupture can usually be diagnosed based solely on history and physical examination findings. Diagnosis is made based on history. I've said that before. Most affected patients report penile injury coincident with sexual intercourse. Patients describe popping, cracking, or snapping sound with immediate detumescence. They may report minimal to severe sharp pain depending on the severity of the injury. Upon physical examination, evidence of penile injury is self-evident. In a typical penile fracture, the normal external penile appearance is completely obliterated because of the significant penile deformity, swelling, and ecchymiosis, eggplant deformity. Upon inspection, significant soft tissue swelling of the penile skin, penile ecchymosis, and hematoma formation are apparent. The penis is abnormally curved, S-shaped. The penis is often deviated away from the site of the tear, secondary to mass effect of the hematoma. If the urethra has also been damaged, blood is present at the meatus. Historically, conservative management was considered at the treatment of the choice for penile fractures, but it consisted of cold compresses, pressure dressings, penile splinting, anti-inflammatory medications, fibrinolytics, suprapubic urinary diversion with delayed repair of urethral injuries. Currently, the vast majority of authors favor immediate surgical repair, citing fewer complications, increased patient satisfaction, shorter hospital stay, and better outcomes. Priapism. Presence of resistant, usually painful erection at the penis unrelated to sexual stimulation or desire. True andrological emergency, which may lead to permanent erectile dysfunction and penile necrosis if left untreated. Priapism is frequently idiopathic in etiology but associated with a number of important medical conditions and pharmacological agents. Two types: low flow, ischemic, veno-occlusive, and arterial, high flow, non-ischemic priapism. Low flow or ischemic veno-occlusive priapism is usually due to full, unremitting corporeal veno-occlusion, venous stasis, and deoxygenated blood pools within the cavernous tissue. Prolonged veno-occlusive priapism leads to fibrosis and loss of the ability to achieve erection. Significant changes at the cellular level are noted within 24 hours, whereas arterial priapism is not associated with fibrotic change. Arterial high-flow non-ischemic priapism, usually secondary to rupture of cavernous artery and unregulated flow into lacunar spaces. This rare type of priapism is usually not painful and results from penetrating penile trauma or blunt perineal injury.